Hello everyone, this is Sarah Brinkman with the National Rural Health Resource Center. I'd like to welcome you all to the first webinar of the 2015 Shift Lean Training and Mini Project. I'd like to introduce our instructor for this course, John Roberts. John is the CEO and President of Midwest Health Consultants. He has an extensive background in successful lean implementation and over 35 years of professional healthcare experience. John received his Lean Healthcare Black Belt in 2009 and serves as a lean coach supporting clients through the implementation of lean concepts and tools in healthcare settings. Over the past 5 years, John has worked with multiple rural hospitals throughout Nebraska implementing lean concepts. So now I will turn it over to John. John, it's *2 to unmute your line.
Thank you, Sarah. Hopefully everybody can hear me now.
Yep, we can hear you.
Great, thanks. Well, welcome everybody to this afternoon's presentation on getting started in lean and lean thinking. I'm very excited to be doing this again. We did it last year for a group of hospitals, and I'm very excited to work again with all of you here over the next few months. What we want to do today is to give you a basic introduction of lean and the principles of lean. We'll also discuss the 8 areas of waste in healthcare, and then we'll talk a little bit about the voice of the customer and how important that is. One of the things I want you to walk away from today is the challenge that we have in healthcare as we move forward with whatever this redesign of the system will be. To be able to do lean and lean work effectively, I think it's very important to ask yourselves why. Why do you want to get into looking at this particular methodology? And what we've seen with hospitals that we've worked with is that they have to have a very strong why as to why they're getting into it. Lean is not easy work, and as you'll see as we go through, it takes some significant commitment from the senior leadership, and it's more than just a set of tools, as we'll talk about. It's really a culture transformation and looking at things in a completely different way. So let's start out by taking a look at why I feel like lean and lean thinking is very important to what we're going to do in rural healthcare as we make this transformation to the new healthcare system, whatever that looks like. You know, everybody knows we're in this change of the U.S. healthcare delivery system. And regardless of what you think about Obamacare or the things that have happened in the last couple of years, the bottom line is that neither party, neither Republicans or Democrats, want to roll back what's happening in the healthcare system. We're seeing more and more attention given to value-based purchasing. We're seeing that efficiency matters more and more to businesses, to consumers, to government, to payers, and we see a lot of regulatory changes coming down the pike with the innovation grants and other things to look at different models of redesigning our healthcare system. The primary reason is that both people on both sides of the aisle recognize this, is that we have a healthcare system that is basically unsustainable as we move forward. So it's not politics that's really driving the reform of our healthcare system. It's really the fact that we cannot sustain what we have into the future. And we'll talk a little more about that in some future slides here. I think you've all seen these kinds of graphs, but it holds true still today. Over the last 10 years or so, the United States spends twice as much as any other industrialized nation on healthcare. And yet, as you'll see, our healthcare status continues to decline. life expectancy has increased only slightly, but compared to another 34 countries, when looking at healthcare status, we continue to drop significantly in a lot of different areas. So that's why people are looking at redesigning the healthcare system, because we're spending twice as much than other countries, and yet the health outcomes that we get for spending that money is continuing to decline. The healthcare cost curve has to bend, and again, because we have a system now that's unsustainable as you look out to the future. And so if we can begin to even take a 1 or 2% gap and bend that cost curve every year, you can see from the graph that we have up that we can see some significant changes in the cost of healthcare as we move forward over the next 40 to 50 years. The red line represents what we're doing right now. If we don't continue to bend the cost curve, so to speak, by 2080, almost 100% of the gross domestic product will be taken up by healthcare. If we can bend that by 1%, which is illustrated by the blue line, you can see that we can begin to at least begin to manage some of those costs, probably still more than we want. But when we begin to look at even just a 2% reduction each year in the cost of healthcare, which is represented by the yellow line, you can see that we can get some pretty significant results in being able to do that and get more out of our healthcare system through value.
Hey, excuse me, John, I just want to note that there's been a couple comments in the chat box that folks are having slight difficulty hearing you, so I'm not sure if you're on speakerphone or on a handset, but just want to let you know that.
Okay, we'll make an adjustment here.
Thank you.
So again, since 1960, healthcare spending has outpaced the gross domestic product by at least 2.5% each year. And again, if we continue on that line, in the next 75 years, healthcare would consume almost everything of our national income, where there would be no more money for things like roads or education or those types of other expenditures, which the federal governments have to really take a look at. So again, we have to be looking at how we can provide more value in the healthcare system. We're beginning again to see many changes in the healthcare delivery system. Hospitals and physicians up until this time really had to look at two choices of dealing with reimbursement. They were either kind of a managed care capitated model or a fee-for-service model. But we're beginning to see all kinds of new paradigms and models in changing the healthcare system in this reform that we're currently undertaking. We're seeing things like patient care, medical homes. We're seeing CMS look at bundled payments, episodic payments, more things like pay-for-performance, value-based purchasing, and accountable care organizations. And again, rural healthcare has been, I think, slower in some of these changes, but again, we're beginning to see that trend change very quickly. A couple of weeks ago, we saw a pretty dramatic statement by CMS Secretary Burwell when she stated the goals for CMS over the next several years to be 30% of all Medicare provider payments to be on alternative payment models and to increase that to 50% by 2018. And again, their second goal that she announced was that all Medicare fee-for-service payments will be tied to quality and value, and at least up to at least 85% by 2016 and 90% by 2018. So whereas PPS hospitals have been in in this mix for a while. I think it's coming quickly to rural healthcare and looking at models that, alternative models of reimbursement, which again are tied to patient satisfaction, to quality outcomes, and first and foremost to value. So these changes, as we've seen with the Center for Innovations with CMS, are really looking at how can we link performance to quality and cost, and how do we tie that back to reimbursement. And so those changes and those tests are happening as we speak. So this value-based system that we're moving to and leaving really a volume-based system is going to create new pressures for hospitals and physicians to eliminate waste, to reduce redundancy, and to really drive down variation in our systems of what we produce in healthcare. Again, there's going to be a big push towards bundled services and looking at how we can integrate the healthcare delivery system as we move forward. In some testimony in Congress about 18 months ago, it was noted that a significant portion of what is spent in healthcare really does not add value for our patients. And we expend about $2.5 trillion in healthcare in the United States. And I just ask you a quick question. What do you think, what percentage of that $2.5 trillion was identified as not adding value to our patients? I think some of you will be surprised with the answer. The answer is around 30 to 50%. It's been reported through several studies that somewhere around 30 to 50% of the total that we spend in the United States does not add value, or in other words, does not increase the outcomes of well-being for our patients. So that's a significant amount of money that we're looking at wasted healthcare dollars. And so I think, again, we want to look at how we can be part of the solution of creating a new healthcare system that provides more value and try to eliminate or reduce as much as possible those wasted healthcare dollars. Those dollars can be categorized in unnecessary services, excess administrative costs, inefficiencies in delivery of care, inflated prices. Interestingly enough, fraud is one of the smaller and prevention failures are a couple of the smaller areas in that area of healthcare waste. So if this figure is even remotely close to correct, looks like we okay, it looks like we're back. So if that figure is even correct, there's a huge opportunity for us as providers, as you as hospitals and critical access hospitals, to look at what we can do to create more value for our patients as we move into the future. It's been said that about 85 to 90% of process steps in any process in a hospital are really non-value added. And I know from the work I've done with many of our hospitals here in Nebraska is that that number is not too far off. That if you take a typical process in your facility and you begin to look at that process from beginning to end, you will see that a majority of the steps in that process do little, if anything, to add value to the patient and the outcomes for that patient. So think about this question. When you're buying a product or service, what's the first thing you look for? You look for price, you look for on-time delivery, you look for quality, you look for service. all those things are important when we're looking at purchasing some kind of commodity or service. And those things are important when we're looking at anything, whether it's a $40,000 car or just going to the local grocery store. We all look for value when we're purchasing those types of items. So the same's true for healthcare. And I think it's beginning as we see more consumer-driven healthcare that our patients and customers are, in fact, looking at the cost of healthcare. They're looking at things like hospital compare. They're looking at outcome indicators. And they're trying to look at how they can pull those things together to come up with some type of basis to balance the price, the availability, the quality of the service. Again, they're looking for the biggest bang for their buck. And again, that's what they're looking for. They're looking for quality. They're looking for value in the healthcare dollars that they're going to expend. So when we're looking at lean and lean concepts, we have to be able to, if we're going to move to this system of being more value-driven and to be able to provide value for our patients, we have to understand what value really means to our patients. And again, we'll talk about that later in this webinar about the voice of the customer. But again, we have to be able to look at what would they be willing to pay for and what are they not willing to pay for. The bottom line is the answer, I believe, in my opinion, has to come from the healthcare industry. We have to look at creating new delivery models that put us in a position to be successful into the future. And any of those delivery models, the hospitals that can position themselves as high quality, low cost providers are going to be situated, I think, pretty well in whatever the redesign of the system is going to be. And we think lean and lean thinking can help hospitals get to that point. So I believe transformation is not optional, that whatever happens as we move forward in the next few years in the changing healthcare system has to be easier, it has to be better, it has to be faster, and again, we have to create and be able to demonstrate value for what we're providing and what we're charging for. I honestly believe that lean and lean thinking is really not optional for many of our providers, that it's really an imperative that we move in this direction to be able to gain efficiencies in the system and to be able, again, to position ourselves to be successful in the redesign of the healthcare system. I would point out that cost cutting and efficiency gains are not the same thing. When you eliminate things in your budget, that's a cost cutting move. When we're looking at lean and lean thinking, we're really looking at efficiency gains. And again, we're looking at going beyond that basic cost cutting exercises that we've done when reimbursement's been reduced. We really want to create this culture that's focused on waste elimination and operational excellence. And the process, the key to this is really looking at process improvement throughout the entire organization and really focusing in on that process improvement. My point is that regardless of how the U.S. healthcare delivery system moves in the redesign, that it's going to be fairly painful as we move forward in this huge of changing the healthcare system and the redesign of the system. Again, we have a system healthcare system that cost-wise is unsustainable long-term. And so that's why these market forces, governmental forces, and other forces are making these dramatic changes right now to be able to, again, create more value out of the dollars they're spending in healthcare. When we look at healthcare, what we call is the holy grail of healthcare is quality, access, and cost. And many times we've you might have heard this saying that you can have two of three, but you can't have all three simultaneously. For instance, if you have very high quality, that somehow will increase the cost. Or if you have astronomical cost, you're going to reduce the number of people who have access to care and being able to do that. We think lean eliminates or reduces that argument by eliminating waste. We can increase quality, we can reduce cost, and we can maintain access to care and do all those simultaneously. And so we think lean has a great opportunity to do the three areas, major areas of healthcare. Again, and I've seen it through the projects that we've done with our hospitals in Nebraska, is we, through these lean projects and lean thinking, have been able to increase quality and at the same time reduce cost. And again, which puts us in a position to be able to provide access to care in our rural areas. So when we look at lean, what is lean healthcare? How do we define it? What does it look like? I guess my main point here is to get you to start to think that lean is not only a set of tools that we'll talk about over the next couple of webinars. It's not only a set of tools that we can use to improve process, to reduce variation, to focus on what's important to the customer, but it also is a philosophy and a mindset. And I want you to think of this in two different areas. One, we have those tools that we can use in lean and lean thinking, but those tools, and I can speak to this from experience with our hospitals, those tools are only as good as the culture that implements those tools. And we did a couple of pilots about 5 years ago with several hospitals here in Nebraska to see if we could learn about lean and lean thinking and how it would be, how we could make it work for a smaller rural hospital. We saw larger urban hospitals using lean. We saw that they were getting some tremendous results with that. So we wanted to see how that would work in a smaller rural hospital that didn't have the numbers of people, money, and resources to be able to implement that. And one of the things that came out of those pilot projects was that to be able to sustain lean and lean thinking for the long term, we really have to also not only get used to looking at the tools that are involved with lean, but we have to look at this culture issue and beginning to change people's mindset from the CEO all the way down to the frontline people on how they view what they're doing and looking at things from a different point of view, again, which is what we call looking with new eyes. There's really 5 guiding principles to lean. Number 1 is to identify value from the customer's perspective. Again, seems pretty simple, but it's very difficult in practice to be able to do that. We have to really look at value and how that changes in the perspective from our patient's point of view. So we have to really constantly be asking ourselves, is this what we're doing? Is this activity, is this process adding value to our customers, to our patients? We want to map out the flow of a service. Again, we want to be able to visually look at processes and be able to identify the steps in those processes. So we'll talk more about that when we look at the tool of value stream mapping. We want to make a product or service flow through the organization. We want to make sure that when they hit the front door in admissions all the way to discharge, that patient is flowing through a consistent pattern throughout that experience with the hospital. We know now with a lot of the work that we've done that there's bottlenecks, there's breakdowns in processes. All those things inhibit flow for the patient. And we'll look more about some of those things when we talk about the waste in healthcare. The fourth concept is what we want to do is create what we call pull.
in a system and not push. And again, it's based on customer demand. We want things to be pulled into the value stream when they're needed, at the exact time they're needed, in the quantity they're needed. And healthcare, particularly today, is pretty much a push-based system. We push things, we push processes into the system regardless of customer demand in some cases. So we'll talk more again about that concept as we move forward over the next few webinars. And then finally, consistently, continually looking at ways to improve. We want to engage everybody on the front line to rethink and to problem solve on a consistent basis and really look at how they can improve their jobs and how they can improve the outputs. So when we look at these principles and how they might look in a hospital, again, we're looking at value from the standpoint of the patient. We're looking at value stream. We're looking at how the process works, what goes into those processes. Again, looking at flow, pull, and perfection, continuous improvement. Lean and lean thinking really comes from the Toyota Motor Corporation back in the 50s and 60s. So many of the concepts you're going to hear when we're talking about lean principles really come from that. It wasn't until in the 1990s that we really kind of took those concepts that they were doing in Toyota and really put the label of lean and lean thinking on them. And so you can go back and see that this, while it's a fairly new concept to U.S. healthcare providers, many of its core roots have been back several decades now. And again, most of the things that we're going to learn and the processes and the tools we'll learn in this particular project come out of the Toyota system. So that's why you'll see a lot of the Japanese terms like Kaizen, Kanban, Hijinka. Those are why you're going to see those names. And again, that gives you some overview of where those come from. We know, and I know through working with the hospitals here in Nebraska, that lean does work, and it can work in a small hospital very well. It's not unusual when we go through a process of lean project to get these kind of results. 25 to 30% labor cost reductions per test, 25 to 40% reductions in wait times, in turnaround times. Again, we've, over the last 18 months, have worked with 12 critical access hospitals here pretty intensely, and the results from those hospitals is pretty significant. Right now, we're looking at, out of those 12 or so hospitals that we've been working with, almost $750,000 in cost efficiency reductions in a lot of the work that we've done. So we know that lean does work. We know it works in a small rural hospital, and we know the results can be pretty significant. Again, our goal is to reduce the cost of care, to improve the reliability of our processes, improve safety, and increase the quality of care as we move forward. And again, one of the pushbacks I get a lot from small rural hospitals, and when we're working with them, is that they're very busy and that people wear 4 or 5 different hats in their position. And I know that most of those hospitals that we work with, people are very busy. And so they always push back a little bit and say, we just don't have time to do and implement lean and lean thinking in our facilities. And my pushback is always, yes, but you may be busy, but I can probably show you that 30 to 40% of what you're spending your time on is not adding value to to your patients and their outcomes. And so while you're busy, many of those things are non-value added. And so if we can eliminate those things, we can free up those times and put that effort into looking at and putting your effort and focus on the things that really matter, that really provide value to our patients and the health outcomes we're trying to get. So again, why doesn't every organization go to lean? Because we've seen that it works. We've seen that we can produce significant impact. It comes from a couple different things. One that I hear quite a bit is that hospitals feel like they're unique. They're not Toyota Motor Corporation where they're producing a car on an assembly line, and that there's too many variations to be able to do this kind of work. And again, I know that it can work and that we've produced significant results in some of the facilities that we've worked with. But again, this is not an easy process. This is not easy work. And so I want to really emphasize that as we move forward and as you move forward, that if you're going to undertake lean and lean thinking and looking at this concept for your hospital, we want you to understand that it's going to take some time. It's going to take senior leadership commitment to it, and it's going to take resources to be able to implement it. Again, lean requires that people learn new tools and techniques, that they develop new processes and procedures, and they begin to look at how to measure value. And those are all important parts of this movement to lean. And again, we're going to look at some of the tools that are in the lean toolkit. And one of the things that people, when they look at lean, they see all the different types of lean tools. And quite frankly, there are probably over 100 different tools that can be used in different portions of looking at lean and implementing lean in your organization. But what we found from the work we've done with our rural hospitals is that the tools that I'll show you in the coming webinars, there's probably 4, 5, 6 tools that can handle almost 90% of the problems or issues you're dealing with. So again, it doesn't have to be an overwhelming effort to try to get lean into your organization. And again, there's just a small number of tools that can take care of a majority of things that you're dealing with in your facilities. Here's just an overview of some of the tools that you might hear in lean. Things like value stream mapping, A3 problem solving, 5S workplace organization, standard work, mistake proofing, Kanban, Kaizen. So those are things you're going to hear as we move forward in talking about some of the tools of lean. So hopefully I've created, at least in this initial discussion, the why and the basics concepts of lean and lean thinking. So let's take a look at the areas of waste that we can see in healthcare. And again, these areas of waste apply to all different industries, but we're going to focus on what types of waste and some examples of how they impact themselves in the area of hospitals and the healthcare system. Again, learning to look at your organization in a new way and looking at ways to identify and eliminate waste is one of the primary focuses of lean. And it's really looking at putting together a systematic way of eliminating and reducing that waste and being able to, again, see it for what it is. There are 8 types of waste. A nice little acronym that you can kind of remember, the 8 different kinds of waste is DOWNTIME. And the 8 different kinds of waste are defects, overproduction, waiting, not utilizing people's talents or their skills or their abilities, transportation, inventory, motion, and excess processing. And we'll take a look at each one of those individually here. Again, our goal in Lean is to relentlessly look at process improvement and perfection and elimination of waste. And waste can be anything, time, money, supplies, goodwill. Again, any of these things can decrease the value we're trying to produce for our patients. A lot of folks will ask me, how does waste really affect me? And again, some of the ways that waste really has an impact on people that they may or may not understand at times is physical fatigue, emotional fatigue, the increase in frustration and stress, a culture that blames other people, and just stealing your time. We have one project that involved the emergency room. In a 12-hour shift, we tracked the motion of the ER nurses in this particular project. In a 12-hour shift, they walked somewhere between 8 to 10 miles in that particular shift. This is a larger hospital here in Nebraska. When we redesigned the process and looked at where they were going in the motion and where they were going to get supplies or to take the patient or those types of issues and looking at their value stream, we were able to redesign that system to cut the motion that they walked in that 12-hour period in half. So when we finished and we could measure it, they were walking somewhere between 4 and 5 miles during that shift. So again, you can imagine how much more energy they had, how much more time they had to devote to the patient and taking care of the patient instead of the wasted motion that they were incurring. One of the things I often talk to my clients about, and when we're working with hospitals in the different projects, is that identifying these 8 areas of waste really takes some courage. Why? Because it often hides itself as work. When we begin to identify, for instance, a value stream, and we begin to identify that maybe 30 to 40% of that process is not adding value to the patient's outcome, you're really looking at somebody's job and the way they've been doing their business. And a lot of times we get the pushback that, so you're telling me that 30 to 40% of what I've been doing is a waste of time? And so we really want to prepare people. We really want to make sure that we're, as we get into Lean and identifying these wastes, that we really have people that have the courage to say, this is not adding value to our patients, and to be able to have the courage to be able to do that and make those changes. When we're looking at waste in general in the different areas of the hospital, we're really looking at what we call value-added work. Those are work activities, steps in a process that actually do add value to a patient and that the patient would be willing to pay for. We have, in this slide, it's called incidental work, but we also call it value-added we call it value-added, non-value-added but required work. Those would be things that you're required to do either through Medicare conditions of participation or state survey or other types of things that may not add value to the patient per se, but you have to do those things to be able to be in compliance with federal rules and regulations or state rules and regulations. And then what we have is non-value-added activities, which are just pure waste that don't add any value to what we're doing for our customers and our patients. So let's take a look at the 8 areas of waste and how they might look in the area of healthcare. The first one we're going to look at is overproduction. Really, overproduction is doing more than what's needed by the customer, or doing it sooner than is needed. And classic example of this may be doing unnecessary diagnostic procedures. Many times we get in to the habit of just in case thinking. So we're going to order extra diagnostic procedures just in case. And again, that would be a classic example of overproduction. Overproduction many times doesn't balance with the demand. It many times leads to an imbalance of work because we're doing the wrong thing at the wrong time. But many times we believe that we're doing it for the right reasons. Another area of waste is the area of inventory. And anytime we have excess inventory, it costs us through either financially through excess inventory or additional costs for storage, for movement of those supplies in inventory, for spoilage or waste. And an example of that might be expired supplies that have gone out of date, or such as medications or other supplies. Again, that would be a waste of inventory and one that we would try to eliminate. The other thing that we've seen a lot in healthcare, and I'm sure this doesn't happen in any of your hospitals, but some of the hospitals that I've worked with, we have some hoarders in the organization. And so we have practitioners or staff that have kind of their own stash of supplies in different areas, just again, for just in case thinking. Because at one time they got chewed out by a physician or somebody else for not having what they needed. They're going to make darn sure that never happens again. And so we have these pockets of inventory around the organization of excess inventory, again, which causes excess waste. A second type of inventory waste that's a little less obvious is that what we call work in process. Anything that is being overproduced, that is causing waiting in the next steps of in the process, again, it's categorized as kind of work in process. This can include patients or specimens, tests, reports, forms, anything, again, that can be used in inventory during our work in process. And again, many times we overlook that. The next area of waste in healthcare can be the area of transportation. And this is really the unnecessary movement of any product. And that product can be patients, specimens, materials, again, in the system. How that might look in healthcare in a hospital setting, it could be such things as a poor layout. It could be a long distance between the laboratory and the ER room. It could be moving patients multiple times when better coordination could have coordinated that movement and reduced some of that transport time. Again, one of the areas of waste that I don't think we really we kind of take for granted in healthcare because we're just so used to it, and that is the waste of just waiting. It doesn't matter what type of waiting that is. It could be waiting for a next event to occur in the process activity. It could be making the patients wait. It could be employees waiting because they're waiting for somebody else in the process to deliver test results or other types of supplies or materials. It could be a patient waiting for an appointment. And again, when we look at some of the projects that we've undertaken with our clients here in Nebraska, you would be surprised at the significant amount of waiting that's occurring within the hospital setting, particularly for our patients. So we want to look at those areas. Another area of waste is the waste of motion, which occurs when we have any unnecessary movement by employees within the system or staff within the system. Again, could be the amount of walking that's done, could be going to get different supplies in different areas, could be just the layout of how we have our workspace put together in our individual areas or departments. Again, anytime a staff person is moving, we want to look at how we can look at reducing that amount of motion in the most effective way possible. Another examples of waste of motion are looking for patients or specimens or treatment or supplies or test results. Again, we see this a lot in some of the facilities we work with, is looking at not having the right information at the right time, or the test results, or having to go track down where those things are. Again, that's all a waste of motion. Again, waste of motion can, as we talked about earlier, can contribute to fatigue in our staff. And we know when people are fatigued and stressed out, and it really lends itself to more errors or lower quality of work. And so that's why we really want to look at the area of motion and how we can reduce that and become more efficient. Another area of waste is what we call rework. Rework is triggered whenever we discover we have a problem or a defect in a patient care activity or process. Examples of this would be medication errors. It could be redoing testing. Anytime you hear the word rework, redone, retest, those are all indications of the area of this waste of rework. And then we have the waste of overprocessing. Again, anytime we perform unnecessary work that does not add value to our patients, our clients, that's the waste of overprocessing or overproduction, or excuse me, overprocessing, or doing any work that's not valued by our customers or doesn't meet the quality standards that we've set for them. It could be things like putting time date stamps on a form, but that data is never used by anybody. So that's really unnecessary overprocessing. And again, we see that a lot in healthcare and with the clients that we've worked with. To give the example of a real life example of how this worked, one of the projects we did, the hospital admission department was requiring a certain form for each patient checking in for day surgery, and that form was sent along in the patient's file. Admissions thought the day surgery staff needed that form, but the day surgery staff separated that form out because they really didn't need it. And so we have this, again, over-processing and not knowing what's required by different departments in the process, in this value stream. And then again, we have sometimes where we build in over-processing into the process. Again, we want to look at more lean, more efficient, and look at processes as we move forward, so we're not putting in artificial standards or barriers or bottlenecks that would create over-processing. I'm sure, again, this never happens in your facilities, but some of the ones that we've worked with, over-processing can mean a patient giving their history or information 4 or 5 different times during their experience with the hospital. Again, this gets very frustrating for them to give the same information over and over and over to different departments throughout the system. And so we want to look at how we can improve information flow in that process and make sure that we have the information where we need it, when we need it, and the right information. The last waste we look at is really looking at underutilizing people skills. Anytime we waste people's ideas or their talents or their time or their skills, that's really a waste of underutilizing people's skills. And we want to engage people to be able to do the things they need to do. For instance, we know that nurses spend a lot of their time with paperwork. And so if we can reduce that, it gives them more time to utilize their talents where they're needed, and that's at the bedside. And so, again, that's an example of looking at how we can put people in the best position to utilize their skills and training. Another area that adds to the waste of underutilizing people's talents and skills and abilities is really not being properly trained in the organization. And again, we know when we work and give people in the right position, utilizing their skills and talents, that it really increases the morale of the culture, and people feel like they're really working in the area that they really want to and feel most reliable and most can produce the most efficiency. So when you begin your lean journey, you're going to be able to see these wastes, and what was invisible to you before, it's going to become very visible to you as you go back to your facilities. And again, I can guarantee you after today, even when you go back into the hospital this afternoon or next week, and you really begin to think about these 8 different kinds of waste, you'll be able to identify those 8 wastes pretty quickly in a lot of the areas that you're working with. And again, we want you to be, as you begin to identify these different areas of waste, many times we get led down a different path because while we look at waste, we may be just seeing the symptoms of that waste. And so many times we have to really go and do a root cause analysis to really begin to look at what's causing the real problem of that waste. And again, that really involves shedding the old ways of thinking and really looking at things from a different perspective. So that's the 8 different kinds of waste, and we'll talk a little bit more about the waste walk you're going to do here over the next couple of weeks here in just a second. But I want to get to the last subject for our discussion on today's webinar, and that is really looking at one of the main principles of lean and lean thinking, and that is looking at the voice of our customer and looking at how do we gather and understand what's valuable to our patients and doing that on a more proactive basis. We know that values-based purchasing is going to include patient satisfaction. It's going to include quality outcomes indicators. So when we look at this new shift in how we're going to be reimbursed and how patient satisfaction is going to be part of that reimbursement formula, I think the voice of the customer even becomes more important to us. And again, why I feel so strongly about lean and how we can impact where we're going with the tools in lean. We really want to gather, as I mentioned before, in a proactive way, what is it that our patients feel like is valuable. We want to analyze those needs, prioritize those needs. And again, value is really defined as anyone whose success, or our customer is really defined as anyone whose success or satisfaction depends on someone else's actions. And so we'll look at that in its broadest sense here in a second. But we have to be able to identify customer and what makes value to them and what makes the experience valuable to them as they come into our hospitals, because that's going to be an important part of how we're reimbursed. And we know that customer satisfaction drives higher quality. And so that's why we want to listen to the voice of the customer. The voice of the customer is really we can capture that data and information through a variety of different ways. We also want to look at the stated and unstated requirements from the customers, both internally and externally. And again, we're in this process of consumer-driven healthcare, and it's being pushed mostly by baby boomers who want care delivered in a much different way than our parents got that care. For example, my parents would go into a physician's office or hospital. They would never ask a question. They just do what the physician told them to do, and they'd be very compliant about that. Now, when I go into the physician's office, I have my internet report. I tell the doctor what I think the diagnosis is and ask him for his opinion. So it's a whole different way, and we have to be very conscious of looking at how we can capture that change and look at that on a proactive basis. I think HCAHPS gives us some indication of that patient satisfaction, but HCAHPS, for me at least, in looking at lean and lean thinking, is like driving a car looking in the rearview mirror. You're looking at what happened 6 months ago, a year ago, and that's really not telling you what's happening now with your patients and their satisfaction right now. So that's why the voice of the customer is very important and a great lean tool. We collect that data through either discussions or focus groups or surveys or tracking customer complaints or just actual observation of how people flow through the system in our facilities. As I mentioned earlier, taking a look at what that broad category of customer is really obviously the patient, but then it's other people too. It's the patient's family, it's the patient's physician, it could be the payer, it could be other regulatory agencies or other caregivers. And also we need to begin to look at ourselves internally and ask ourselves, aren't departments actually customers of each other? Because we all have a stake in making this process flow through the organization. No patient comes to a hospital and only deals with one department. There's always 5 or 6 different departments involved with that value stream from beginning to end. And so really looking at this in a different way and making sure we're taking care of our customers and knowing what they value, again, is all that's involved here in identifying the voice of the customer. Again, we know that customer satisfaction on profitability has been widely researched and reported, and we know that there's a direct correlation between patient satisfaction and employee satisfaction and ultimately profitability of that organization. We've seen it demonstrated in various studies through different organizations, through different industries. And so again, this voice of the customer, the patient, is critical. We know for every patient that complains, there's 20 more that won't complain, but they won't come back to your facility. And again, we want to understand the patient's needs and desires and what they value because we know it has a huge impact on our organizations. I really like the Malcolm Baldrige National Quality Awards definition of voice of the customer. Again, they describe it as the process of capturing patient and stakeholder-related information. And that capture is proactively and continuously captured the stated, unstated, and anticipated patient and stakeholder requirements, expectations, and desires. So I think that's one of the best definitions of voice of the customer that I've seen. So that's a little bit about voice of the customer. Because of time on this first webinar, we don't have time to go into it a lot of detail, but there's a variety of different ways and tools that we can use in looking at voice of the customer. But again, it's very important when we look at lean and lean thinking that we're continuously keeping 3 principles in our mind. One is, how does this add value to our patients? How do they describe and determine what is valuable to them? how do we eliminate waste in the system? How do we drive out and reduce those 8 areas of waste? And then finally, how do we continuously improve on what we're doing? How do we look at measuring and sustaining what we're doing over time and really engaging our culture to be problem solvers on a continuous basis? So hopefully I've given you a good overview of lean and lean thinking in this first webinar. Our next 2 webinars will get into some of the actual tools of lean and go through those in more detail. And then our final webinar will talk more about metrics and the culture issue that we want to try to generate with this type of lean process. So as was mentioned earlier, you have an assignment for the next three weeks or so, and that is the waste walk exercise. In Moodle, you have the documents that you need to do it. What we basically want you to do is to put together a small team of people, and for the next 3 weeks, do what we call waste walks, to go around your facility and observe how things are working in your facility in different areas and identify all of those different kinds of waste that we talked about today. And we want you to look at those things and do that once a week for the next several weeks. And you can either report on Moodle each week, or you can do one final report after on the 4th week. But we want to get you used to just going out and identifying that waste, and to be able to look at it and to be able to identify. And then we want you to do a little brainstorming on how you might reduce that waste, or some brainstorming on things you could do to change that to be able to do that. We want you to submit your lessons learned report on the types and kinds of waste you identified. What was the cause? Did you identify the cause, the root cause, or the symptom? How was the customer impacted? What kind of bottlenecks did you identify? What kinds of ideas did you come up for eliminating that waste? What was really difficult in identifying some of that waste? And what were some of the greatest opportunities that you identified to be able to eliminate or reduce that waste? So that's your assignment for the next few weeks. I think you'll find it a very fun and interesting assignment, and I think it's really the best way to get you to really begin to look at lean and lean thinking from the perspective of how do we eliminate waste in the system. So with that, I would be glad to answer any questions you might have, either on the information I covered today or on your exercise for the next few weeks.
Great, and I'm just going to take a quick moment. I know that there's some folks who needed to hop off, so I wanted to thank everybody for participating today and remind you that going forward we're going to be using Moodle as our main source of communicating. So if you have questions that don't get answered here by John in the next few minutes, you can feel free to post them in our technical assistance forum on the site. I'll also be posting the assessment link there, which you can see on the website, on your screen right now as well. If you could take a few minutes to complete that assessment, we'd really appreciate it. If you do have any questions for John, it's *2 to unmute your line. We'll continue to record, and we'll post the final recording on the Moodle site for all of you who have to jump off early. Does anyone have any questions for John? We have a question in the chat box from Mercy Harvard Hospital. Did John say that there was a tool to use for the waste walks? Yes, that is in the Moodle site. When you get to the Moodle site under section 3, there is a waste walk guide that has some information for you about how to conduct waste walks, and a waste walk worksheet, the identifying waste worksheet, which you'll want to download and use for your waste walks with your team. And then when you've completed your waste walks, you'll finish the final, the icon there under section 3, which is your submission. And again, if anybody has any questions, they can press *2 to unmute their line.
Well, if there's no questions, then I would just thank everybody for today. I'm really excited to be a part of this journey with you guys. And I want to make sure, first and foremost, that I'm available to be contacted either by email or phone at any time to provide technical assistance to you, either through the waste walks or any concepts that we've covered or anything that I can do to help you along this journey. So I want to make sure that it's clear that you can contact me at any time.
Wonderful. Thank you, John, and for a great presentation, and thank you everyone else for joining us today. We will be in touch over Moodle, and we'll hear you all again in a few weeks when we get